So here we go, Chapter 14, Medical Overview. So most of the time, people don't call us when things are going well, right? Let's just, start there. They have some form of either medical emergency, traumatic emergency, or both. When we are talking about traumatic emergencies, it is some form of physical force has been applied to this human, and that is what's causing them their problems. It's pretty easy to figure out a lot of the times when it's a traumatic emergency because most of the time things are staring right back at us. I was hit in the head with X. All right, well, your problem is going to be head, neck, spine, anything that's actually physically connected to that. We look in the areas that we know that force or whatever was applied to, and we find our injuries. When we look at medical emergencies, we are looking a bit more deeply, right? Most of these problems live under the hood. It's a bit more of questioning, like we learned yesterday. It is some form of disease process that is causing this problem, and it's not always clearly evident, but we do most of the time expect certain signs and symptoms in certain patient presentations to go along with certain illnesses. Let's take a look at our friend here in this picture. So right off the bat, tell me what you notice about this guy.
Seems like he's complaining about chest pains.
All right. So let me ask you a question. Generally speaking, what do you think your chest pain patient looks like?
Not breathing well, low respiration rate.
So Alex, think about it a little easier than that. Your typical chest pain patient, your typical patient that has some sort of heart trouble, what do they physically look like as a human?
Maybe a little bit older.
All right, older. What else?
Usually not fit or overweight.
Not fit, yeah, maybe a little doughy around the middle. People that look like they aren't in the greatest of condition are generally the people we associate with chest pain. So now let's take a look at our picture here. Does this guy look older?
No.
Does he look out of shape?
No.
What do you think his complaint probably is? Because clearly he's clutching at his chest a little bit. What do you think is a more logical complaint for this guy? Do we look at him and think, oh yeah, walking heart attack?
No, definitely not a walking heart attack.
So you were talking about respiratory rate and not breathing so well.
Asthma, possibly.
Yeah, so our respiratory patients aren't always the 95-year-old grandma who's smoked for 40 or 50 years. Our respiratory patients could be anybody. Asthma is a disease that affects just about everyone. It is a disease that starts very, very young most of the time. Our respiratory patients are gonna, most of the time, present as any normal person, but with these for associated signs and symptoms. So they're gonna complain of shortness of breath. They're gonna look like they're having difficulty breathing. So that's where we get into that rate, rhythm, and quality and noiseless, effortless, and painless assessment of our breathing. We start to add in some skin color, temperature, and condition changes, and you can really look at and not only hear from the patient telling you, but point your finger at things for your respiratory patient that will jump right up and say, hi, I'm a respiratory condition, please fix me. If we see poor chest rise and fall, what do we associate that with? If my chest wall isn't moving far enough, what's not going on?
You're not getting enough oxygen inside your lungs.
Right, we're not filling up those lungs, we're not getting gas down to those alveoli, and we're not creating that pressure difference necessary for that diffusion to take place. And sooner rather than later, our patient becomes pale. And then the worse their respiratory condition gets, they become cyanotic. And we start to see the perfusion issues created by not enough oxygen being available just because they're not moving their chest wall enough. Difficulty moving air. When do you think we would notice that?
when we're checking for respiratory rate and doing our assessment?
Yeah, what specifically, how would you know that they were having a difficult time moving air? When you're checking your breathing assessment,
They're not getting enough of a breath coming out of oxygen, or chest rise and fall is not adequate enough as a normal human being would be. A lot of struggling to get that air in and out.
all right, I like it.
Breath sounds?
Yeah, breath sound. That's why I'm such a huge proponent of always checking your lung sounds. Check them early, check them often, because you can actually hear the constriction, like with wheezes. You can hear things like crackles that are going to tell me if the alveoli in those capillary beds, think back to the video and back to the picture that we have. If those alveoli and capillary beds are normally really, really close, anything that increases that distance, like fluid or inflammation or irritation, is going to make that gas more difficult to get out of the alveoli. And maybe physically they're not having a lot of trouble moving that air, but the diffusion isn't happening quite as readily as we want it to, because that air now, that gas that's in those alveoli, has to move across a greater distance in order to get into the blood. So all of these things kind of come into play when we are evaluating a patient for respiratory type signs, symptoms, and complaints. You know, clearly, if they called for a respiratory issue, their complaint is going to be shortness of breath. I'm having a hard time breathing. But the more of these boxes we check and see, all right, now we're starting to see some cruddy skin color temperature condition. We're seeing that their chest isn't rising and falling the way it would when they breathe normally, because maybe they're starting to get tired, or maybe they're not getting enough gas to actually even make that happen anymore, because they're having a difficult time either moving that air in and out, or that air is now having a difficult time actually getting into the blood. You know, we start to see things fall off one at a time. We have shortness of breath. Shortness of breath is going to cause them to breathe faster. Breathing faster is going to cause those muscles to wear out. Those muscles wearing out is going to make it difficult to move air. The difficulty moving air, we start to see poor skin color temperature condition, going from pale in the early stages to now cyanotic in our patients turning blue. And maybe we now can't correct it with just a little bit of oxygen. We wind up having to now ventilate this patient because they're having poor rise and fall of the chest and difficulty moving air and turning blue. So now we'll take a look at our next picture. What do we notice about this guy right here?
Well, he's definitely older, heftier, a little overweight.
So is this more our typical chest pain type patient?
I would think so, a little bit more than the other guy for sure.
Yeah. A lot of this stuff is boiled down to logic, especially in the very beginning. Now, I'm not saying that this guy right here couldn't have a bad heart and really be having a cardiac emergency, but this all speaks a little bit to our general impression. When I show up and I'm forming my general impression of this patient right here, I don't look at him and immediately think, all right, he's probably got a cholesterol at 250 and a history of hypertension, and this is my typical heart attack patient. When I look here, you do see a guy that's a little bit older. You see a guy that's a little bit heavier, probably not is in quite as good a shape. And those are some of the issues that feed our cardiovascular emergencies, that some you can change, some you can't. You can't change how old you are. You can't change genetics and family history. Sure, if you know you have those things pulling against you, if you're a little bit older and you have family history that supports, you know, a cardiovascular diagnosis, yeah, you should take better care of yourself. But some of that stuff's not necessarily in the cards. You know, some things can be changed, some things can't. Any issues that are going to affect the circulatory system, so the heart, the blood vessels, anything like that, are really cardiovascular emergencies. If you look at some of the signs and symptoms, though, we're going to see some shortness of breath. Why do you think our patient who may be having some sort of cardiac event would complain of some shortness of breath.
Blood isn't being pumped into the lungs as efficiently.
Yeah, even a little easier than that, right? Those two things, cardiac and respiratory, are intertwined. They are dependent on each other so that they can accomplish their task. If our cardiac system's not working up to snuff, sooner rather than later, our respiratory system is in one way or another going to suffer for that. And it's going to present initially as shortness of breath, just having some difficulty breathing. Maybe I walk across the living room and I get tired and I have to sit down. A lot of that, especially with a patient who has a cardiac complaint, is going to be able to loop right back to the fact that they are having cardiac issues. Chest pain is the one that we're always looking for. That neck and jaw pain and back pain, that's that R in OPQ-RST. We're having some radiation here. Why do you think pain radiates? Why do you think chest pain isn't just chest pain and we can all continue on our merry way?
I mean, the heart's not working efficiently and the lungs aren't working efficiently, the respiratory system, so it's going to start drawing blood from certain areas, causing nervous system effects, trying to gain as much as blood and oxygen as it can to support the problem.
That's what I was just looking for somebody to say, is the nervous system. So think of the way the body's wired. The way the nervous system works is it's all electrical current. All of the wires come from our central nervous system. So all of these sensors in our body that are feeling that pain in the chest exit from our spinal cord. And that electrical current and those electrical wires have to pass through other tissues. So the pain sensation from the chest actually originates from back at the central nervous system, and it passes through places like the neck, the jaw, the back, because those nerves all travel from the same spot through the neck and the back and the jaw. So we'll start to see our patient having some of that radiating pain just because that's the way that the pain is traveling. What about nausea and vomiting? Why do we think that those might be pretty significant as far as our cardiac patient is concerned?
I think it goes back to the nervous system telling you that there's a problem.
It absolutely does. The nervous system saying that there's a problem, and it's going to start, like Alex said a few seconds ago, we'll start to pull some blood away, so that places that aren't as important aren't going to be perfused as well. Then you start thinking about, all right, well, the body's response to all this, if the heart's not working and not pumping blood around efficiently, the body's going to release epinephrine. That epinephrine is going to make that heart rate speed up. It's going to make that respiratory rate speed up. So as those things are getting faster and blood isn't getting to the GI system, that epinephrine causes that upset stomach, that nausea, that vomiting. And a lot of the times when we're evaluating somebody for a cardiac issue, some of our only signs and symptoms might be right here and right here. Especially when we start talking about elderly people who sense and feel things differently than younger people do, females for whatever reason, and diabetics. They don't have your stereotypical crushing substernal 10 out of 10 chest pain that radiates to the neck and jaw. A lot of times older people will say nothing more than, I'm a little short of breath and my stomach's a little upset and I just don't feel well. And you'll get them to the emergency room and they'll put them on a cardiac monitor, and the next thing you know, they're on their way up to the cardiac cath lab because they're having a humongous heart attack. None of the things that they said to you are going to sound anything like they're having a chest pain. They're having acute coronary syndrome, right from the protocol. Well, chest pain with X, Y, and Z. It all sounds very non-committal. It sounds like, oh, well, they're a little short of breath. They're nauseous. Maybe it was something they ate. Maybe it was something they didn't eat. Maybe they just don't feel well. And you wind up never hearing the word chest pain, neck and jaw pain. You know, as much as a lot of our patients do present typically, there are some times where they present with atypical signs and symptoms. You maybe don't get as much information and as much of a direction as you wish you would. Does that mean if they don't complain of chest pain and we didn't give them aspirin that we were wrong?
No.
No, because they didn't complain of chest pain. Nothing about shortness of breath, nausea, and vomiting makes me think I'm going to give this patient 324 milligrams of aspirin and tell them to choose them up. That's part of operating within our protocol. If they don't tell you, hey, I have this discomfort, I have a pressure or a pain in my chest, we have no way to really investigate that. We have no way really to run that to ground. Of course, we're going to ask them about their shortness of breath. Of course, we're going to take their vital signs and do all of that stuff and treat what we can. But aspirin is for chest pain. Nitro is for chest pain. If you're interviewing your patient and getting their medical history and chest pain doesn't come out in the wash, there's not a whole lot you can do other than treat their shortness of breath, have a bucket ready for their nausea and vomiting, and transport them to the emergency room. So now let's talk about our friend right here. What's going on with Grandpa?
Probably a headache, migraine, or something.
Yeah, so now we're talking neuro stuff. Some of the big things we get called for as far as neurological emergencies go are seizure, stroke, or your everyday run-of-the-mill syncope. Now, seizures are chaotic brain activity. When our patient goes into ventricular fibrillation and we're going to apply the AED and work a cardiac arrest and send an electrical current through them, that ventricular fibrillation is chaotic electrical activity in the heart. And you see the heart, if you've ever seen the video inside a chest of someone in VFib, the heart's just quivering, like if you had a bowl full of Jell-O and hit the side of the bowl. It just sits there and jiggles. Well, when a patient has a seizure, their brain is having that exact same chaotic activity, sending off these chaos electrical impulses. And instead of the brain quivering, because the brain's not a muscle, that's not what it's meant to do, it sends those electrical impulses out to the entire body. That's why we'll see a patient who loses all muscular control and will be on the ground sort of just shaking and twitching when they have a legitimate seizure, because those chaotic messages to the body from the brain are causing those muscles to quiver almost like the heart does when patients in VFib. Stroke comes in two flavors. With stroke, we have a ischemic stroke or a hemorrhagic stroke. Ischemic stroke means there's a blockage in a cerebral artery. So years ago, when you took an AHA class, they used to call strokes brain attacks. They compared them a lot to heart attacks. When a patient's having a heart attack, we have a blockage in a coronary artery causing death of heart muscle, right? That is like the book definition of myocardial infarction. Blockage of a coronary artery causing a patient to have death of heart tissue. When we have an ischemic stroke, we have blockage of a cerebral artery. And what do you think the blockage in that cerebral artery is causing?
Death of brain tissue?
Absolutely. Death of brain tissue. We have blockage still in an artery that the artery is supposed to be supplying oxygenated blood to tissue. If there is a blockage and no blood is getting by, the brain is going to become ischemic and eventually infarcted. And that means that piece of tissue is dead. When we see patients that have a stroke, and especially an ischemic stroke, we have infarction of that brain tissue causing death of that piece of tissue, and it's all looped right back to blockage in one of those cerebral arteries. Believe it or not, those are the strokes that are way more treatable and much less detrimental to our patient. Because the other kind, a hemorrhagic stroke, for anybody that has read the shock chapter, what are we talking about when we talk about hemorrhage?
Fluid or blood loss.
Yeah, fluid or blood loss. So we have especially blood loss if we're going to talk specifically to hemorrhage. So we have a cerebral artery now if we have a hemorrhagic stroke that has ruptured, and all of that oxygenated blood that was supposed to be supplied to the brain tissues is just leaking. And is there extra room inside of our patient's skull for all of that blood to just be floating around?
No, definitely not.
No, there definitely isn't. So that blood is just going to continue to build up and build up and build up and increase that intracranial pressure. Our stroke patients, especially our stroke patients that are having a hemorrhagic stroke, one of the big complaints that they're going to have is like 10 out of 10 worst headache ever that came on like a rocket. It's just like all of a sudden they were sitting there, no problem at all, and sudden onset of the worst headache ever, like a thunderclap of pain in their head. That is like our typical presentation for a hemorrhagic stroke. Our ischemic stroke is going to develop a bit more gradually because of the progression of everything. First of all, that clot starts to form, and maybe that brain tissue gets a little ischemic. And with the ischemia comes a little bit of dysfunction. And then that clot gets a little bigger, and now we have a complete blockage of that cerebral artery. And that cerebral artery getting blocked is still causing ischemia. Ischemia just means that there's not enough oxygen to perfuse that tissue. It's not happening well right now. And we start to see now our signs and symptoms of stroke progressing and beginning to get a little worse, and your patient looks a little bit worse to us. Has anybody who's recently been to any type of doctor's appointment seen that sign on the wall that says fast? And it's got the cartoon looking guy with a weird smile and arms doing wonky things and mumbling incoherent words.
Yeah, Teddy Bruschi has an advertisement for it too.
That's the same stroke scale, more or less, that we do in the field as providers. Those are the same things that we're going to test, because that points us towards the likelihood that our patient is having a stroke. I always forget about Teddy Bruschi having, would he have 2, 3 strokes?
He had a couple. Sure.
Yeah, at least, right? And then last but not least, we have syncope. Syncope really is just sort of an unknown loss of consciousness. This can happen for any reason. It can happen for no reason. Sometimes it's caused by low blood pressure. Sometimes it's caused by dehydration. It is just a brief alteration in your patient's level of consciousness. And the real kicker to a syncopal episode is they normally wake up just as their head's about to bounce off the floor, and then their head bounces off the floor. Syncopal episodes, normally they will report something like, I felt dizzy briefly, and the next thing I know, I was whomping my head off the tile. Most of the time, that's about all the notice that they get. And sometimes it can be figured out with lab work and imaging and stuff like that in the hospital. And sometimes it just goes down as a syncopal episode and the patient had a fall. Syncope is one of those weird ones that we may never actually get any answer to. It could happen to anybody. Could be young, could be middle-aged, could be old. It doesn't really make that much of a difference. If you are evaluating them for some form of neurological problem or some unknown loss of consciousness and everything appears to check out, then they had a syncopal episode. You know, if they don't have a seizure history, if they're not showing signs and symptoms of stroke, if their vital signs are remarkably normal for somebody who just all of a sudden lost consciousness, you know, their blood sugar is normal, they're not a chronic drug or alcohol abuser, you know, you start to really run out of things that we can look at that would cause this neurologic dysfunction. And sometimes it is just a syncopal episode, and that's the way it gets kind of hashed out. But either way, for us, do you think that the treatment really changes a whole bunch?
No, it should stay the same.
Yeah, as long as they're conscious, alert, and oriented when we get there, we treat the associated injuries from the fall, we treat the associated problems from the syncope, and we just don't let them get any more injured. It's pretty straightforward. So next we're going to talk about is GI problems. So some of the more common ones we're going to see are appendicitis, diverticulitis, pancreatitis, and I'll throw another itis in there, cholecystitis. Anybody remember what itis means?
Inflammation?
You got it. So appendicitis, inflammation of the appendix. Diverticulitis, inflammation of the diverticulum. Pancreatitis, inflammation of the pancreas. And the last one, cholecystitis. Cholecystitis is your inflammation of your gallbladder. These are your patients who have what they would call a gallbladder attack. So appendicitis is inflammation of the appendix. What will happen a lot of the times with this is your patient will have that textbook stabbing, really, really uncomfortable, painful right lower quadrant pain. Has anybody had their appendix removed? Nobody? All right. Generally, it happens to younger age, kids up to the age of like 13, 14, early teens is when we're looking at things like an appendicitis. What happens is with the inflammation, that appendix will swell. And when it does, it begins to thin out the membrane of the appendix a little. And the sicker the patient gets, the thinner the wall of that appendix gets, the more actual bacteria and infectious process is actually leaking into our patient. So when an appendix actually ruptures, that pain will go from very spot specific, you know, that right lower quadrant pain, oh my God, this hurts so bad, to diffuse and spread towards the umbilicus or towards the patient's belly button. Why do you think as the patient progresses and gets worse, that pain spreads out a little bit?
Because if it ruptures, the actual inflammation is then spreading throughout the abdomen.
Yeah, and all that poisonous stuff that's actually in the appendix is now out and about, running amok. With our diverticulitis, our diverticulum, that's when we have inflammation sort of tucked inside of loops of our bowel. This can be something that is particularly common with the elderly. A lot of the times it is just unmanageable abdominal pain, and it could be anywhere because there are just loops upon loops upon loops of intestine running throughout our entire abdominal cavity.
I got a quick question, Tommy.
Go for it.
So something like that could that cause septic shock, or the pain that they would be in, would first responders be able to get there, when they're calling before septic shock would really set in?
So are you asking about the appendicitis?
Yes.
It absolutely could cause septic shock. It doesn't always take a super, super long time for sepsis to set in. Not to mention the fact that as that appendix sort of thins out and begins to leak a little, even before it ruptures, it's already leaking all that bad junk into the body and into the bloodstream. So we may see some signs of septic shock. And really one of the downstream problems for a lot of people when they have an appendicitis and the appendix does rupture is infection. They wind up on IV antibiotics for at least a day, probably still inpatient in the hospital. And then they wind up on a pretty extensive oral or PO antibiotic.
Thank you.
Yeah, no problem. Now we got pancreatitis. Pancreatitis is inflammation of the pancreas, and our pancreas lives pretty much in the middle of the two upper quadrants of our abdomen. So we'll feel that inflammatory type pain high up in the upper abdominal quadrants when our patient's telling us, you know, what they have for signs and symptoms, or when we're doing our palpation of the abdomen, because that's where their complaint lives. We're going to have some pain in the upper quadrants, and that's generally our pancreatitis. The pancreas is not as prone to things like rupture or anything like that as the appendix is, but the pancreas only takes so much insult before it stops doing its job, and its job is to help us control our blood sugar. So if your pancreas decides after enough attacks of pancreatitis that it's not going to do its thing, that's how we see patients all of a sudden becoming diabetic. And then I added one, cholecystitis, gallbladder inflammation. Your gallbladder is really, really important to digestion of food, specifically digestion of fatty foods. A lot of the times what we'll hear for a complaint with people who are having a gallbladder issue is after a particularly heavy sort of high fat meal, they have some pretty significant stomach pain, maybe some cramping, and they have right upper quadrant pain because that's where the gallbladder lives. They have what we'll call rebound tenderness. So when I push down, the pain might go away a little bit instead of getting worse. But then when I let go, that pain comes flooding back. They may also have pain that's referred to their opposite shoulder. Remember, all of this pain sensation and all of this feeling is traveling along these neural pathways. It's traveling along these nerve lines. Our typical cholecystitis or gallbladder patient is generally going to fall into a middle-aged type person, and they have what they're called the 4 F's of cholecystitis. So it's female, fat, 40, and fertile. That is your patient who is like spot on your gallbladder patient. And if they're also complaining of all these things after a significantly high fat, heavy meal, we've dotted our I's, we've crossed our T's, we've kind of gotten to the bottom of what is causing their right upper quadrant pain. Other than that, treatment for a lot of these things don't change a whole bunch either, because we're not going to be taking out appendices. We can't prescribe antibiotics for our diverticulitis. We can't correct our pancreatitis. We can't do gallbladder surgery. So a lot of what we're doing is, again, treating those associated signs and symptoms, provide as much supportive therapy as you have to, and transport our patient to the hospital, because definitive care and long-term care and maybe some form of surgical intervention is really what is going to make this patient better. Sure, if their pain is so intense that they're having difficulty breathing, can I give them some oxygen? Sure. Can I position them on the stretcher so that they're a little less uncomfortable? Sure. Can I do much to actually correct their issue? I can't. But now we're going to talk about one that is spot on deadly and is something that we can treat. What's this look like to you guys?
Allergic reaction.
Yeah, allergic reaction. I heard somebody say anaphylaxis. Absolutely. The immune system job is to identify things as either self or not self. If it identifies something as not self, the immune system's job is to go on and get rid of that. It is something that the immune system does all day, every day. That's what its function is. It's great at it. That's how we remain healthy. When we have a patient who is having an allergic reaction, having even a minor allergic reaction, the immune system identifies something has been introduced into the body that is not supposed to be there, and it triggers a response. And that response is most of the time fairly minor. We'll see some redness, we'll see some swelling at the site, think like a bee sting. You know, the bee is injecting venom when it stings you. You know, you'll start to see maybe even a little bit of rash looking thing around the bee sting, maybe a little bit of swelling and some increase in temperature in that area in particular, because the body is generating an inflammation. The body is actually now making those tissues inflamed in order to get more blood to the area and more immune response to the area in order to wall off whatever it is that's causing that minor allergic reaction and get rid of it. They kill it off. When a patient has an anaphylactic reaction, instead of that minor localized reaction, the immune system identifies the fact that something has been introduced into the body that it doesn't want there. And instead of having this very regimented, very normal response of inflammation in the area and going in, building a wall and keeping that stuff from spreading throughout the body and then going off and killing it, the immune system freaks out and has this very, very exaggerated response everywhere. You'll see inflammation in the entire body, something that looks an awful lot like that. You'll see a drop in your patient's blood pressure because some of those immune response mediators, some of the chemicals that actually are involved in an allergic reaction or an anaphylactic reaction, cause vasodilation. On top of causing vasodilation, it also causes the vasculature to become leaky. So now we have a tank that's too big, we have a tank that is leaking, and we have what kind of pressure do you think when we take our patient's blood pressure and they're having an anaphylactic reaction?
Very high blood pressure.
So you think the blood pressure would go up if we increase the size of the tank?
Oh no, I'm sorry. Decrease because it's not enough to fill up the tank.
You got it. We would have the blood pressure actually be profoundly low. What do you think would happen to their heart rate and their respiratory rate then?
It's going to increase.
Yeah, because the body's going to do what it can to try and move around what it can. So heart rate's going to go up, respiratory rate's going to go up. We're going to start to see swelling in all of the tissues because this is happening everywhere. And all of the vasculature has now dilated and become leaky. So we have freestanding fluid, all sorts of places that it's not supposed to be. We have no pressure left in the vascular system. We have a heart that is beating like crazy, trying to push blood around with no pressure to push against. And we have a respiratory rate that is continuing to climb. And we have now found our life-threatening anaphylactic allergic reaction. You guys have something in the toolbox that can treat it though. What is it?
EpiPen.
Yeah, my EpiPen, for an adult patient, 0.3 milligrams of IM epinephrine with an auto injector. I'm going to take that auto injector and I'm going to push it against my patient's leg until it clicks, and I'm going to hold it there for 10 seconds. I want to make sure all of that epinephrine gets into my patient. And when the epi's done, I massage the area and I reassess my patient. And what is that epinephrine going to do when it gets into my patient's bloodstream?
Take a shot at it. I think it's going to help close up those vessels so the blood can pump through it.
Yeah, it's going to cause vasoconstriction now. And that blood vessel size is going to close down and it's going to stop all that leakiness. And if I take the tank and I shrink it back down to size, what happens to my blood pressure?
It'll start to rise back up to a normal state.
Blood pressure is going to go up to a normal state. You're absolutely right. And then all of that swelling that was going on, if epi is constricting all those blood vessels, what happens to the swelling?
It starts to decrease, I would think.
It starts to decrease. You'll start to see now the mucous membranes going back down to normal size. You'll actually start to see the constriction that you were hearing in the airway with maybe, I don't know, some stridor getting better. your patient's lung sounds will actually begin to improve, because if we have all that leaking and all that swelling in our airway, we're going to have some effect on our lung sounds there. And all of this was just done with that one quick 10-second injection of IM epinephrine. Immune problems, especially anaphylaxis, because anaphylaxis is the big one we're going to talk about, are really one of the times where, as an EMT and even as a paramedic, you can straight witness yourself pull somebody back from the brink of death. Anaphylaxis is one of those times where it is absolutely game time, because this patient's entire body is trying to kill that patient. And it's all just a miscommunication. All right, moving right along. Now we are talking about, and why this is the picture for it, I haven't a clue. Endocrine emergencies. What just happened? I gotta stop pushing buttons. Endocrine emergencies. One of the big endocrine emergencies we're gonna talk about, and you guys are gonna see all the time, is patients with diabetes. Diabetes is, again, one of those things that comes in one of two flavors. We either have type 1 or type 2. Our type 1 diabetic is someone whose pancreas works not at all to help control blood sugar level. Because what does all the cells in our body need an adequate supply of?
Oxygen and sugar.
Oxygen and sugar. When we have a patient whose pancreas isn't functioning and they are a diabetic, doesn't matter if it's type 1, doesn't matter if it's type 2. Let's just talk about the fact that the pancreas is not adequately supplying the body with insulin. The sugar molecule, if you were to look at it next to a cell, the sugar molecule is really big compared to what it's trying to get into to help that cell create energy. So without insulin to actually now facilitate that sugar getting into the cell and open the door so that that sugar can go in, all of that sugar, all it does is float around in the bloodstream and never help the body actually create any energy. That insulin is the key that opens up the cell, that allows the sugar to go in and adequately feed that cell and help it create energy. If your pancreas isn't functioning up to snuff and it is not producing insulin the way that it needs to, in order for your body to now use any of that sugar, all that's going to happen is your blood sugar is going to go up. None of those cells are going to get the sugar that they need to create the energy that they have to have. And you know the message they send back to the body? Hey, we're starving down here, feed us. So your patient, especially your patient who's a newly diagnosed diabetic, or maybe not even yet diagnosed diabetic, you may be the person that finds this out. The cells send the message back to the body through the brain that says, hey, we're starving down here, feed us. And the brain says, all right, I'm going to feed you. So our undiagnosed diabetic patient eats more. And when that food is processed and broken down and more sugar is created, that sugar goes out into the bloodstream. But what's not happening? The pancreas isn't producing insulin, and insulin's not letting even that increased level of sugar into the cell. So the cell isn't getting any of that sugar to create any of the energy that it needs. And the cell sends another message back to the brain. Hey, we told you we're hungry down here, feed us. And the brain goes, okay, gonna feed you. And then your patient will eat some more. And the process just continues and continues and continues. And none of that sugar does anything but float around in the patient's blood, essentially turning their blood into pancake syrup that is loaded with sugar. And the cells are down there going, hey, we're hungry down here, would you feed us? and blood sugar level continues to rise and rise and rise and rise and rise. Diabetes is a very, very complex illness. And believe it or not, for the most part, high blood sugar is not the one that we get called for as often. Low blood sugar is. Now, I know we've talked pretty wholesale about how the cells of the body, all the cells of the body, need oxygen and sugar. But most of the cells in the body will actually continue to create energy even without oxygen and sugar through that anaerobic metabolism process we talked about. Which ones don't do that?
Brain and the heart. And the
The
lung.
heart will, the brain won't. The brain will not switch over to anaerobic metabolism. And if the brain doesn't switch over to anaerobic metabolism and there's not enough sugar available, our patient who's got a low blood sugar, most of the time the complaint is they're not acting themselves. And you'll show up and your patient will be in the living room howling at the moon like a crazy person because their brain is malfunctioning because it doesn't have the sugar necessary to actually supply itself to have normal brain function. So a lot of times your diabetic patients who's got a low blood sugar is going to be altered and nasty and just acting way out of sorts. Could be even somebody you know. Let's face it, you guys work in the city you live in. You know, this could be someone who maybe you hung out with and you show up to their house and they're acting like a complete lunatic and mad at everybody, wanting to fight. And it's all because their brain does not have enough sugar to function and do the things necessary to create energy and act like a normal human. That's a self-limiting problem because sooner rather than later, without the sugar, the brain shuts off and your patient will be unresponsive. Part of the reason we make sure when we are talking about giving oral glucose to a patient that they can adequately follow our instructions and protect their own airway is because if we don't get that sugar introduced to them quickly enough, they'll wind up unresponsive and will create an airway problem. Remember, airway is the beginning of the primary assessment. It's where all of our reassessment goes back to. So if we have an airway problem, we just have a big problem. All of the things we talked about are really sort of just like generalizations. Making sure that we get an accurate medical history from our patient, so that OPQRST in that sample, you know, making sure that we get all the information we can, we ask all the questions that we need to, is going to be important. It's going to help you make your working field diagnosis. It's going to make, you know, help you treat patients more appropriately. Dispatch information is going to be given to you. Your dispatch is going to give you, you know, what the call coded as when they run it through the EMD system. And they're going to give you sort of your initial response and your first thought. But like when I was talking to one of the groups yesterday, you know, you may get sent out for a chest pain. And the whole time you're on the way there, you're thinking, all right, chest pain. Gonna have to evaluate the cardiovascular system. Maybe I'll have to give some aspirin. Maybe I'll have to give some nitro. Maybe I have to check out the respiratory system too. I'm gonna listen for crackles. And this is all on the way to the call. Haven't laid eyes on the scene yet, let alone your patient. And the whole time you're thinking cardiac, cardiac, respiratory, and you're batting those things back and forth in your head. And then you get there and the patient's got an 8-inch kitchen knife sticking out of the right side of their chest. Well, okay, is that still pain in the chest? It is.
Yes. Huh.
But is it cardiac in nature?
No.
Probably not. So don't get distracted. Don't get locked in on, all right, I got sent here for a chest pain. I got sent here for a chest pain. I'm going to have to do X, Y, and Z. We get our chief complaint from our patient. Because my patient who's got the 8-inch kitchen knife stuck in his chest is going to say, boy, this hurts. but they're probably not going to say anything about crushing substernal 10 out of 10 chest pain that radiates to their neck and their jaw and their back. They're going to say, right here where I got stabbed, it's really uncomfortable. Yeah, well, that makes plenty of sense to me. And part of the reason that we do everything the exact same way, the exact same time, all the time, is so that we don't get sort of laser focused in on what we got sent there for. We're still going to do that scene size up in our primary assessment. We're going to start to develop that general impression. We're looking at the patient. Is this patient behaving normally the way a patient should behave? Look for any visual clues that point you towards your patient is unconscious or has some form of obvious life-threatening bleed or significant difficulty of breathing. Get your patient's level of consciousness. That whole, Larry, hey, how's it going? And Larry looks at me and answers my questions normally. Cool, I know Larry's alert. And I ask him my 4 questions. Who are you? Where are you? About what time it is or what day it is? And what's going on? Because that what's going on gives me my chief complaint. That is Larry telling me, hey, this is what is bothering me the most. If my friend Larry is speaking to me, I know some things already, right? There's parts of this assessment that are already done for me if I know Larry is talking to me. I know airway is already being managed by Larry himself if he is able to speak to me. But I want to make sure that I pay that as much mind as I have to. So I will say out loud, well, my patient's airway is patent because Larry is conscious and alert and able to talk to me. I'm going to still go through my primary assessment. Airway, breathing, circulation. So I've done A, we're moving on to B. I'm going to check respiratory, rate, rhythm, quality. I'm looking to make sure that my patient's doing it often enough, doing it well enough, so we're moving our chest in and out, and that quality, noiseless, effortless, and painless. If I find a problem, I fix the problem. So this is where during my primary assessment, my patient's going to get some oxygen. How am I going to give oxygen to my patients here in class?
Bas-
15 liters on a non-rebreather mask.
You got it. High flow, 15 liters per minute with a non-rebreather mask. If my patient was unconscious, how do I address their airway? So I have an unresponsive Larry now. Larry didn't answer my questions and he didn't respond to my sternal rub. What am I going to do for Larry's airway?
Your OPA.
Yeah, if I don't expect any trauma, he gets a head tilt, chin lift, and an OPA. If I think he's been victim of some sort of traumatic event, he gets a jaw thrust and an OPA. Now Larry's airway is open, clear, and secure because I opened it, I secured it, and I assessed it to make sure that I didn't hear any snoring, see any gurgling, see any obstructions. Perfect. Airway's done, we move on to breathing. I'm still looking for rate. Is he doing it fast enough? Or is he doing it too slow or too fast? Rhythm. Is it regular? Quality. Is it enough chest rise and fall? Is it noiseless, effortless, and painless? None of these things change. After I make sure that rate, rhythm, quality, and all of that is in order, he still is going to get some oxygen, 15 liters per minute with a non-rebreather mask. And now that I've assessed and treated everything with airway and breathing, I move on to circulation. When I assess my patient's circulation, what am I looking for?
Radial pulse and skin temperature, color.
You got it. If they're conscious, I check just a radial pulse. Maybe I check both radial pulses if I want to be fancy. But if they're conscious, that's what they get. And I look for skin color, temperature, and condition. Radial pulses and skin color, temperature, and condition are going to tell me how my patient is perfusing themselves. When I evaluate their circulatory status, I'm still looking for rate, rhythm, and quality. How fast? Is it regular or irregular? And what does it feel like? I combine all of those things together And putting all those things together gives me my transport decision. I make my transport decision now because I have completed all of the things that are of dire importance. I have assessed and treated any problems with my primary assessment, airway, breathing, or circulation. And those are the things that are going to keep dear old Larry alive. So as long as I have assessed and treated those, then I can move on, but not until I decide that, hey, this is a high priority transport. We're going to bring them to the closest appropriate facility with an ALS intercept en route. Then I begin my secondary assessment. And my secondary assessment finds what the actual problem is when we're talking about a medical patient. So that's why I ask them all these questions, and I'm getting into their actual physical medical history a bit with sample and the history of their present illness, their HPI, OPQRST. How did the problem start? Does anything make it better or worse? What does it feel like? Notice I've kind of left out pain, right? Because it doesn't always have to be in relation to pain. How did this all begin? Okay. Does anything make this problem better or worse? What does this problem feel like? People are always going to have some sort of description, whether it's abdominal pain, whether it's respiratory distress, no matter what it is, they're going to have something to describe the quality thereof. All right, does this problem move anywhere, or is it just where you've described it to me? How bad is it right now on a scale of 1 to 10? And how long has it been going on for? It doesn't always have to be pain, 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 pain. This is really just a history of what's going on in this very given moment in time. How do I get the S in sample, the signs and symptoms?
What you've already seen from the patient, and you can ask them if they're feeling anything else.
Perfect. So the signs, the things that I've physically observed by myself, and then the symptoms, the things that the patient has told me. Awesome. I want to know if they have any allergies. I want to know if they take any meds. That's the A and M in sample. And then P, pertinent past history. The last time they had anything to eat or drink and the last time they used the facilities. And then the events leading up. So onset is how fast did this come on? You know, E, events leading up. What were you doing at the time? Onset is sort of the how did it begin? The events were you doing anything at the time that, you know, we can start now? All right, this wasn't chest pain at rest. This wasn't the patient we talked about yesterday who got woken up from a nap by cardiac related chest pain. This was, again, that guy who was on the treadmill for the first time in 22 years, you know, cleaned all the hanging laundry off of it and hopped on the treadmill for turning over his new leaf and wound up with some chest pain that now maybe gets better. Which one of those two people is sicker? The patient who got woken up from their nap or the patient who hopped on the treadmill without consulting his physician first?
Both are equally as bad.
The one from the nap.
I could make my peace with actually both of the things that you guys just said. The one from the nap scares me more. The one from the nap is somebody, it's like, man, you were doing nothing, and all of a sudden something was uncomfortable enough that you got woken up from minding your P's and Q's. The guy from the treadmill may be every bit as sick as the guy from the nap. It's going to depend on some of the other questions we get answered and some of the other things that we ask, like maybe provoke. Does anything make this pain better or worse? What do you think the guy who got woken up from his nap is going to say? Do you think that pain's going to get better or worse?
Probably gonna get worse.
Probably going to get worse because he was minding his own business when it happened.
hmm
The person who just hopped off the treadmill when he felt some chest pain, do you think his pain's going to get better or worse?
It'll get better.
when he does what?
Relaxes and sits
Yeah,
down and
sits down and stays off the damn treadmill. So there are some sort of fluid back and forth type things. It's still chest pain. We're still going to treat it the same way. But again, we're sort of gathering all this information and putting our picture together to figure out how sick is my sick person. All right, that is it for chapter 14. Anybody have any questions? It all kind of circles back to, we go into all of our patient assessment with, you know, a little bit of information from dispatch and an open mind, and ask a whole lot of questions of our medical patient. And then we kind of just run to ground anything that they tell us. It's really, that's it. That's how that is accomplished. That's why we have set everything up the way that we do. It's why we ask the questions in the order that we do. And it's why everything starts with that scene size up in primary assessment. Because if I turn myself into a patient and don't do my scene size up right, well, I'm already a negative on the situation. If I make it through the scene size up and I don't make myself a negative on the situation, but I skip through my primary assessment because, you know, my patient looked really sick, I just made them worse because I didn't check to make sure that their airway was open, clear, and secure. I didn't assess and treat the problems with breathing. I didn't assess and treat the problems with circulation. And I spent a bit too much time muddling around as opposed to addressing the things that were real for life problems. All right, I am bringing up chapter 11 right now. And as soon as I get that up and on the screen, we'll take a short break and we'll come back and we will take a run at chapter 12, shock. And we're going to spend a bunch of time on this here this morning. This morning, because apparently that's become a difficult task. All right, we are going to talk shock. So I have used the words shock and hypoperfusion pretty well interchangeably since we started mentioning these two words. Shock is inadequate tissue perfusion. So inadequate delivery of oxygenated blood to the cells and the tissues. It is pretty well a blanket term. Shock and hypoperfusion are the exact same thing. And what we are going to start to look at is, what is the underlying cause? What is at the root of all this? Because what do you think the solution for the most part is for us? If oxygen delivery to the tissues is our problem, what's our fix?
administering oxygen.
You got it. Oxygen is going to be one of the things that we want to make sure we are supplying to our patients who are in shock. If the cell's needs aren't getting met by the delivery of oxygen and glucose, they switch from that aerobic metabolism to anaerobic metabolism. That anaerobic metabolism causes all the rest of these problems at the bottom of that screen. They are still going to produce energy, but when oxygen and glucose are the fuel to produce that energy, they create about 19 times more energy per unit. So that means every molecule of glucose or sugar or oxygen that goes into that cell creates 19 times much more energy for that cell than energy that's created without sugar and glucose and oxygen. If we've switched to anaerobic metabolism, we have a whole bunch of toxic substances beginning to build up. And if oxygenated blood flow is not getting to those cells and not getting to those tissues, None of that is getting carted away. All of that is just sitting there and building up and building up and building up and steeping that cell in all that acidic waste product. Sooner or later, when that happens, we have some cellular functions taking place. The sodium potassium pump is what actually pumps those two chemicals into and out of the cell. They are electrolytes, sodium, potassium, both. They have an electrical charge, and they are responsible for the cell being able to do its thing. When that sodium potassium pump fails, all of this poisonous acidic waste product floods right into the cell. And sooner rather than later, when all that waste product winds up on the inside, we have cellular death. When that cell dies, it's not coming back. And if that one particular tiny little cell is being bathed in all this acid, so aren't all the cells around it. And all of their sodium potassium pumps are beginning to fail. And instead of just having a cell die from all of that acidic waste product after anaerobic metabolism, we'll have big packs of cells dying. And sooner or later, tissues will die. And once tissues die, organs die. And once enough organs die, whole organ systems will die. And once enough organ systems have died, the entire metabolic machine breaks down, and the end result is your patient has died. Period. That is exactly the way shock works. We have impairment of oxygen and sugar delivery. We have impairment of energy production. We have a humongous increase in the acidic waste products. We have metabolic processes starting to flunk. And when they do, all of that acidic waste product goes into the cell. The cell eventually dies. The tissues eventually die. The organs eventually die. The organ system eventually dies. And once enough organ systems have decided to go kaput, that cellular metabolism throughout the entire body is just no longer going to happen, and we wind up with a dead patient. That is how shock kills everyone.
Tom, what is like a reference of a time frame of a good period? I mean, obviously immediately to get to the patient when they're not going to get enough oxygen and sugar in their body to prevent shock. But where is it there a threshold of where it's like almost unreversible?
So as far as like time on a clock, there isn't one.
Okay.
Because some of the stuff that we're gonna talk about here in just a few minutes, it's a great question because that's logical, right? You would think, all right, 5 minutes, 6 minutes, we know if a patient is in cardiac arrest and not getting, compressions, we know 10, 15 minutes, they're done for.
Right.
But as far as shock and, straight hypoperfusion, there is no real time frame because a lot of what goes on inside the body is the body's attempts to compensate. And depending on how healthy someone is, depending on how good of a shape someone is in, as a general rule, will depend on how their body's going to respond to this and how long you can delay some of the more negative aspects of it. What you will see that may be a little more helpful than me telling you there's no real time on a clock we can look at is there are very, very significant changes in our patient that we'll be able to see that will tell us compensated versus decompensated, decompensated versus irreversible. Because shock follows a very natural, logical progression. The body will mount some resources and attempt to try and compensate. And sooner or later, the body runs out of the ability to compensate and we change to decompensated shock. And decompensated shock shows us some more negative signs and symptoms. And then as decompensated shock goes on uncorrected, that's when we start to see things that are irreversible and will eventually lead to death.
Okay. It's almost like a 3-stage area it goes into, and the progression is just like a chain reaction unless you get to it as soon as possible.
Spot on, you got it.
Okay.
So what are cells? Cells are the basic unit of life. Every single tissue, every single organ, every single bit of us is made up of cells. In order to continue doing their job and continue supporting our person, they need energy to stay alive, and they create that energy by reacting with oxygen and glucose to form what's called ATP, adenosine triphosphate, ATP. As long as there is oxygen and glucose, we're in good shape, because without oxygen, there's no energy, and without energy, there's no life. And if there's no life, we start to see signs and symptoms of shock. Shock sounds like this big, like overarching, like bottomless pit of things that we need to know. I'm sure after reading chapter 12 last night, you probably put the book away and went, what have I gotten myself into? But it's really a lot simpler than that. There are 3 places we're going to have a problem with this. And that's why I said it's a lot like plumbing. We're either going to have a problem with the pump, we're either going to have a problem with the pipes, or we're either going to have a problem with the volume. So if the heart's not working correctly to pump oxygenated blood around, then we're going to find signs and symptoms of shock. We talked about anaphylaxis and the pipe problem. We have wide-scale vasodilation. If we have that huge vasodilation, we have a pipe problem, because now the pipes are too big and they become leaky, and our pipe problem is going to lead us to our failure to adequately deliver oxygen and glucose. And then the more sort of easy to understand one that we're going to talk about today is a fluid problem. If you look at your patient and most of their circulating blood volume is on the floor, is that blood actually going to be delivering any oxygen and any sugar?
Nope.
Yeah, the simple answer is no. All that blood that's on the floor was meant for a job. And if we lose that blood volume, the body can't replace it fast enough to overcome the problem. So we're going to wind up with an oxygen and glucose delivery issue, which is going to lead us to shock. Now I know you guys were probably hoping to never have to see this picture again, but you'll see it today, and then you'll probably see it at least once more. Our respiratory A&P and pathophys, those alveoli, as far as gas goes, what do they have a lot of in them when I take a breath?
Oxygen, rich oxygen.
Yeah, so we're rich in oxygen. The blood that's being pumped out of the right side of the heart, what does that have not much of?
Oxygen.
All right. So what does the alveoli have not much of in it?
Carbon.
Yeah, carbon dioxide. And what does that blood from the right side of the heart have a lot of?
Carbon dioxide.
Carbon dioxide.
Bingo. Which way do gases travel?
From high to low.
Yeah, they travel from high to low concentration. So the gas that's in high concentration in that alveoli, that oxygen, is going to travel into the bloodstream. The gas that is in high concentration in the blood from the right ventricle is carbon dioxide. It is going to travel from high concentration to low concentration. They're going to wave at each other as they go into and out of the blood respectively. And now we have oxygen on that hemoglobin, and the hemoglobin's job is to transport that oxygen back to the left side of the heart to be pumped out into systemic circulation to wind up down at the cellular level. So now we're at the cellular level on the right side of this picture. And we have that oxyhemoglobin, that oxygen-rich blood, and those oxygen-poor cells. Gas still travels high concentration to low concentration, so that oxygen is going to move out of the bloodstream and into the cell. In normal function, what did that cell create a lot of when it was making energy?
Heat.
Heat.
Okay, I'll take heat, but what gas specifically?
Is it hydrogen?
Well, there's only 2 that we've talked about really, right?
Carbon.
Carbon dioxide.
Carbon dioxide, yeah. The main waste product of normal cellular metabolism is carbon dioxide. If the cell is carbon dioxide rich and oxygen poor, and the blood from the left side of the heart is oxygen rich and carbon dioxide poor, oxygen moves into the cell, carbon dioxide moves out of the cell. We wind up right back at the left side of this picture by way of the right atria, right ventricle, and all those gases are just going to exchange. When we have a patient who is hypoperfused, either this isn't happening or this isn't happening. And instead of now the cell using oxygen to create that energy, it burns things like fats and other things that are going to create much more acid. So with all of that acid being created, we can go right back to the cells soaking up all that acid. Eventually, the sodium-potassium pump fails. That acid rushes inside of the cell explodes and dies, and then whole pieces of tissue, and then whole organs, and then entire organ systems, and then the entire organism whose main function was cellular metabolism, dead, muerta, no more. All because oxygen and carbon dioxide weren't being exchanged appropriately for one reason or another. And the three reasons that we're really going to look at are pipes, pump, and fluid. That is it. We can trace all of the problems with shock back to these three things. We're looking here at what's called the perfusion triangle. So the heart's job is to pump. If there's damage to the heart, that damage is going to decrease the heart's ability to properly pump blood around. If it's not moving enough blood, it's not supporting perfusion. And if it's not supporting perfusion, we wind up right back here, and all that oxygen and all that carbon dioxide is not moving around appropriately. And if it's not being moved around appropriately, the cells are going to create energy. That's what they do. So they switch from aerobic to anaerobic, and it starts this whole cascade of bad things happening. And that eventually leads to a failure of our perfusion. The same thing goes with the pipes, the same thing with our container. If our container dilates rapidly and winds up 2, maybe 3 times as big as it's supposed to be, we can't generate blood volume fast enough in order to refill that system. It just can't happen. So if the heart doesn't have some pressure to pump against, is that blood actually going anywhere when the heart contracts?
No.
No, it's just going to be like a ripple on a pond. Nothing actually is moving. It's just a wave now. All right, great.
The heart's working like too hard, and it starts overwork compensating.
It does. And that's one of the physical things that we can start to witness when we start getting into what are the signs and symptoms of shock. And then the fluid problem, that's easy to understand because we already have half of it. If there is not physically enough blood inside this person for the job of perfusion and the job of metabolism to take place, we're not going to adequately deliver oxygen. We're not going to adequately remove carbon dioxide. And if those two things aren't happening, the cells are going to find another way. So here's my inadequate volume. We have an uncontrolled leak. That uncontrolled leak is going to do some things. When we find a patient who's bleeding and bleeding pretty profusely, one of the first things that we'll see is a drop in systolic blood pressure. Why do you think the systolic blood pressure goes down?
Because when blood's pumping, it's going to contract through that to push it forward. If that makes sense.
It's
I
like
think I
losing pressure.
Say that again?
I was saying it's losing pressure, right?
Yeah, we're losing pressure. If there's not enough blood, we're not filling the tank anymore. And if the tank's not full, pressure goes down. We can have decrease in whole blood. That means my patient is leaking all over the floor. Or we can actually have a decrease in blood plasma. So more than half of your circulating blood volume is plasma. Plasma is just salty water. And the plasma is actually what makes all the rest of those formed elements actually be able to move around. Without an adequate supply of salty water pumping up our blood volume, all that would be left would be red blood cells, white blood cells, and platelets. And your blood would be more like sludge than blood. It would never go anywhere. Burn patients, a lot of the times, are the ones we think of as having a volume problem, but not actually having a bleeding problem. Your skin's real main function is to keep your body a closed environment. Its job is to keep things out and keep things in. When we have a patient who's been burned, especially over significant portions of their body, we can actually see plasma really just evaporating from the damaged tissues and the damaged blood and the damaged vascular structures. And they wind up not with a bleed, they're not actually leaking blood all over the floor. Their blood plasma is just evaporating into the environment, and they still wind up with a volume problem. And really the last way that we think of people losing blood volume is excessive nausea and vomiting. Elderly people and babies especially, a couple of the things we'll talk about right now are the fact that normal aged adults, so people that aren't at the outliers, you know, they always, anytime you talk about how sick somebody gets, they normally talk about how it's really, really bad for the elderly, it's really, really bad for the very young, and people in the middle are generally a lot more okay. Elderly people and children don't have the same type of fluid reserves we do. Elderly people and children don't have the same compensatory mechanisms we do. And constant bouts of nausea, vomiting, and diarrhea for babies particularly, but even the elderly, can actually make them lose enough fluid that they wind up hypoperfused and dehydrated. And we still see signs and symptoms of shock. And again, we're not looking at somebody who is bleeding all over the floor.
So is that why is saline basically just plasma?
It would be nice if it was. Saline has the same salinity, but so it's got the same amount of salt content as blood plasma does. But what it's missing is a lot of the proteins and a lot of the other stuff that helps kind of correct some of these problems. All saline really is legitimate just salty water. When I call plasma salty water, I guess I don't quite give it its due, because it's got a lot of like clotting factor type things in it. It's got a lot of other very important proteins that help the body maintain homeostasis. Because at the end of the day, if we just filled somebody with saline, that would all just leak out into the tissues sooner rather than later, and we still would have a volume problem. So patient who have a problem with volume, they need to increase their blood volume to maintain perfusion. Someone who is bleeding needs to have that bleeding stopped. That's why when we look at our primary assessment, I told you we're always going to look for X first, because we want to make sure that this patient isn't bleeding to death, because bleeding to death takes less than 2 minutes. We're talking probably 90 seconds for someone who's got an uncontrolled hemorrhage to pump all of their circulating blood volume onto the floor. And in the field, if we don't stop the bleed, there's nothing else we can do. If we have problems with fluid from, say, a burn or nausea, vomiting, diarrhea, fluid, something like saline, is going to be adequate to replace that. It will work over a short period of time. So our patient who's profoundly dehydrated, probably hypotensive, complains of nausea, vomiting, or excessive diarrhea for a couple days, or your pediatric patient who just looks sick as sick gets with those sunken in fontanelles, the soft spots on their heads that look like divots now. That's someone who's profoundly dehydrated and would probably benefit from an intercept with a paramedic. We don't carry anything that replaces whole blood. Years and years and years ago, when paramedics would show up to a significant trauma, they would pump as much normal saline into a person as humanly possible. And everybody would be happy when we got a decent pressure, right? Oh, we take it and the systolic blood pressure is normal. Yeah, we're 120, we did a good thing. But what does saline not do?
Gonna go with supply oxygen.
Yeah, it can't transport oxygen, it can't remove carbon dioxide, and we didn't fix the hypoperfusion. So someone who is actively bleeding and hemorrhaging all over the place, your first order of business, do not go any further until you figure out where that hemorrhage is and plug that hole. Because that is going to be what prevents them from getting into the decompensated shock and the, irreversible levels of shock. Your patient who's in hypovolemic shock, hypo-low volume, so low volume of blood from fluid depletion, sure, fluid will correct that. But if it's from actual physical blood loss, stopping the leak is a BLS skill, and it is handy as all get out when it comes time to talk about significant external hemorrhage causing shock. When we talk about vessel tone, so now we're into pipe problems. Which one of these two blood vessels do we think has a higher pressure in it, left or right?
Left.
Left, because it's full. The blood inside of that vessel is actually exerting some pressure on the inside of that blood vessel. On the right, we have a blood vessel that looks like it's 2, maybe 3 times too big, and it's dilated and barely full at all, and no pressure is built up in there. In order to have an adequate blood pressure, the tone of these vessels must be maintained. Our nervous system, our sympathetic nervous system, is the one that's responsible for this. Our sympathetic nervous system is also the part of our nervous system that is going to help our body compensate and fix some of the problems associated with shock. When vessel tone gets too big, there's less resistance. Less resistance means less pressure. Less pressure means blood is not going to be pumped around effectively. Our sympathetic nervous system senses all of these things. There's all sorts of receptors inside of these vessel walls that actually respond to how much pressure is inside that wall. And our body's ability to compensate by kicking in that sympathetic nervous system will release epinephrine. And we already talked earlier today about what epinephrine does. It'll get down to the business end and start to clamp down some of those structures. So now when my body compensates and releases all that epinephrine, we wind up back over here. And we have vessel tone that is normal and a blood vessel that is now full. So let's say, for argument's sake, we find a patient who we think is in shock. We won't get into the whys or what fors just yet. But let's say we think it's in shock and we think they're having a problem with inadequate vessel tone. And when we get to them, they have a somewhat normal blood pressure. Maybe instead of 120, maybe we're looking at like 116/78. But they're a little tachycardic, so their heart rate's a little high. They're a little tachypnic, so they're breathing a little fast. What does it sound like going on there?
That the heart's trying to work faster to compensate for the loss of pressure.
The heart's trying to work faster. The respiratory system's trying to work faster. epinephrine has gotten down to the vasculature and caused this to happen. Epinephrine is what your body uses to compensate for shock. So if you find a patient who you think has sustained an illness or sustained an injury that would cause them to be in shock, some of the first things that we're going to see are signs of vasoconstriction, an increased respiratory rate, an increased heart rate, and maybe some slight changes in skin color, temperature, and condition, because our sympathetic nervous system has kicked into gear and done all of the things that we expect it to do in an effort to maintain pressure and maintain perfusion. So epinephrine is going to be one of the things that we're looking for floating around inside of our patient when we think that they have sustained something that will put them in shock. Doesn't matter if it's pump, pipe, or fluid. We're going to see these things as the body's initial response, and that is the primary way that the body attempts to compensate. So when the body's compensating and doing all this extra work in an effort to support perfusion, do you think that it does it forever?
No, eventually it's going to seize up.
Yeah, eventually the body loses its ability to compensate. So if we saw the pressure maintain and the heart rate go up and the respiratory rate go up initially when my patient was compensating and still doing pretty well, what do you think we start to see when my patient is now decompensating?
You're gonna see that blood pressure drop.
Blood pressure will start to go down.
The
Pulse
heart rate.
Heart
Yeah.
rate and respiratory rate for a very brief period of time may get out of control high. You may see a very, very fast respiratory rate and a very, very fast heart rate. But is that helping?
No, it's coming towards its endpoint of overload.
You got it. We are getting to the point now where the heart's beating so fast that it's not adequately refilling between beats. The respiratory rate is so fast that we're not getting any blood down to those, not getting any gas down to those alveoli. And if the heart's not refilling with blood and pumping blood around effectively, and those alveoli aren't getting filled with oxygen-rich gas, perfusion now is at the point where things are beginning to fail, and that failure is going to now go from decompensated to irreversible. It is much easier to identify shock early in the game and treat it aggressively so that way we don't get to the decompensation. We don't get to the points in this game where things are more difficult to reverse, things are more difficult to fix. So these are our categories of shock. We've already really beat up the hypovolemic version. We've talked about hemorrhage. We've talked about blood being all over the floor. We've talked about non-hemorrhagic hypovolemic shock from things like burns or nausea, vomiting, diarrhea. Next, we'll move on to cardiogenic shock. First and foremost, what does cardiogenic shock sound like?
The heart, the cardiovascular system.
Yeah, the heart's ability to pump is what we're questioning here. So if my patient has a long-standing cardiac history and they've had a bunch of heart attacks, is the heart going to be able to pump quite as effectively?
No, it has bruising that has been occurred, and it will not work at 100% capacity.
Right. And if you look at all the other things on that list, depressed pump function, abnormal heart rhythm, if the heart rhythm isn't nice and regimented and normal like we expect it to be, think VFib. VFib's very erratic, very irregular. The heart's just shaking. That abnormal rhythm is causing a cardiac issue, and that cardiac issue is leading us right back to the center of this picture, and we're talking shock. Congestive heart failure is, we'll talk about that on Wednesday. Just know that congestive heart failure is another thing that can lead to cardiogenic shock. Congestive heart failure is sort of a topic all by itself. So we've got the cardiogenic portion down. Anything that is going to interfere or negatively affect the heart's ability to be used as a pump is sooner rather than later going to circle us right back to shock. Now let's go to distributive. So distributive, we have a couple of things to chat about here. Anaphylactic, we already got pretty well. Anaphylactic, we have that wide scale vasodilation from all those chemicals being in our body, all the response of the immune system causing our vasculature to dilate, causing all those blood vessels to become leaky, fluid is everywhere, and if my vasculature is too big, what kind of pressure do I have?
Low pressure.
Low, because the tank's not full. When we see septic shock, it is largely the same sort of progression. But instead of the immune system now causing those issues, septic shock means the immune system actually didn't do well enough. And some form of bacteria has gotten into the blood and been allowed to pretty much run rampant and caused vasodilation, wide scale throughout the whole body. The chemicals that the bacteria are releasing are causing that vasculature to become leaky. And if we have a tank that is too big and not enough fluid to fill it, and that now tank is becoming leaky, we have septic shock. So if we have someone who is looking like they're in shock and complaining of recently having something like, I don't know, a UTI or a pneumonia. UTI means urinary tract infection. Those are some of the big things that will cause distributive and septic shock in our patients. And then last but not least, when we talk distributive shock, we're going to talk neurogenic. So what does neurogenic shock sound like it has to deal with?
Nervous system, the brain.
The nervous system. So your central nervous system is the brain and the spinal cord. And the brain and the spinal cord is what's responsible for sending out all of the brain's messages and receiving all of the brain's information. And if we have a break in the spinal cord, so somewhere along the way, the spinal cord has been injured and now no longer transmits messages any further than where that damage is. Someone who's having a distributive shock from a neurogenic cause like that is unable to control their vessel tone past wherever that break in the spinal cord is. So what we'll see with a patient who's in distributive shock from a neurogenic cause is wherever they have that break in their spinal cord, they will look like a normal person. They'll look just like people are supposed to look, because above the level of that spinal cord damage, their brain is still sending out messages for their body to control their vascular tone, and the vascular tone stays normal. What do you think happens below the level of that break in the spinal cord?
It all starts to malfunction.
Things start dying.
Yeah, it starts to malfunction because now nobody's in charge. That vessel tone will actually dilate. And below the break in that spinal cord, we'll see vasodilation and pipes that have gotten too big and not enough fluid to fill those pipes. And there's no pressure left in the system. So now blood can't get there and blood can't get back. And we see distributive shock clearly defined below wherever the break in that spinal cord is. This is something that we see most often in patients who have just received some form of spinal injury. So this is your pretty significant trauma patient who, was having a perfectly normal day and now can feel nothing below, say, I don't know, their nipple line. We have vasodilation below the nipple line. We have distributive shock below the nipple line. And think about how much of their body that truly is because above the nipple line, we see a patient who looks normally perfused and not having any issues, but everything below where they had that spinal cord injury is not in good shape.
So Tom, question, how does a situation like that get addressed? I mean, so the nervous system has an issue from the spinal cord down, and everything's going to start going out of whack, and not working properly. You know, the valves, you know, vessels will open up wider and so on and so on. Are we chasing to fix those issues that we see physically, or like we going right trying to like stabilize the spine and make sure that at least by doing that we'll help control some of the symptoms that occur throughout the rest of the body?
So good question, and I like the way you phrased it. Are we chasing? Because yes, we are chasing.
Okay.
Really, what we are fighting in any type of shock situation, whether it's any of the things that are on this page, what we're fighting is time. We're on the clock. The only thing that fixes shock is definitive care. We can give an EpiPen, right? No problem. I'll give you an EpiPen. We'll get you to the emergency room. My piece of this will go fine, I promise. But is that chemical, is that immune response still happening inside the body? Probably. I can stop you from bleeding all over the floor. I can backboard you and do whatever needs to be done to make sure that, you know, your neurogenic shock doesn't get any worse. But I can't very often, especially when it comes to shock, fix the problem because the problem becomes systemic. So what we're doing most of the time is identify. So actually look at what's going on and see that this is becoming a problem. Most of our treatment for shock is purely supportive. It is, we're going to oxygenate these people. So high flow O2, non-rebreather mask, 15 liters per minute. We're going to lay them flat on their back. We want to keep them supine because we don't want a system that already has no pressure in it having to fight gravity to perfuse the brain and the heart and the lungs. So we lay them flat and we keep them warm. Why do you think keep them warm makes that list?
I mean, I would think just keep the blood flowing as equal as possible throughout the body so it doesn't constrict to other areas.
That's more the laying them flat portion, right? Because if there's not enough pressure, blood's going to start following the path of least resistance. But what happens when you get cold?
Is it
Hypothermia.
because the body's going to try to, you want to try and help regulate the body temperature because the nervous system's out of whack and it's not going to keep the body temperature where it should be?
True, true. Let me ask you this. You guys go out middle of January and you're going to
Your muscles,
in nothing but your pajamas.
your muscles overworked. You start shaking.
There you go. You start to use your muscles a lot more because they're going to shiver. And if you're using muscles more, what are you using more of?
Heat and blood.
You're creating heat. But what physically does your body need to create the energy to make those muscles shiver and create that heat?
Oxygen and glucose.
Oxygen and glucose. And what's the problem here? Just say it again.
Not enough oxygen and glucose.
Right. So if we don't keep these people warm, they're going to fly through the rest of the oxygen and glucose that's in their body in an effort to try and warm themselves. And in fact, they're just killing themselves faster. So we're going to talk obstructive shock. There's metabolic and respiratory. We're going to leave that alone for a little bit. We'll get into that when we talk respiratory conditions a little bit. I think tomorrow or Thursday. I'm not sure which one. But let's talk obstructive shock. So what does obstructive shock sound like?
Something's blocking a passageway or something obstructing it from getting from point A to point B.
You got it. And what if that obstruction was something preventing blood from returning to the heart? What part of this whole equation would fall off?
Your
If
pump,
blood flow is being returned to the heart, not being returned to the heart, what's the heart not doing?
It's not getting oxygen from the lungs.
The body's not going to get oxygen from the lungs, right? Because the heart's not actually going to refill to pump that. So when we have things like tension pneumothorax means so much tension has physically built up in this patient's thoracic cavity that the vena cavas have been closed off. Remember, superior and inferior vena cava, they're both really, really important blood vessels, but at the heart of them, they're just veins. And if they're veins, that means they don't have an overabundance of pressure inside of them. And if they don't have pressure inside of them, when the increase in pressure inside my patient's thoracic cavity gets higher than the pressure that is actually inside that vein, they get pinched off. And their job is to return blood from the body to the heart on the right side so that the right side of the heart can pump that blood to the lungs so that that blood can get oxygenated, and that oxygenated blood can go to the left side of the heart, and the left side of the heart can pump that blood out through systemic circulation to the everywhere else. So an increase in pressure inside the patient's chest wall, inside that thoracic cavity, closing off those vena cavas, is actually going to cause obstructive shock. Blood flow is being obstructed from getting back to the heart for one reason or another, and the heart cannot adequately refill. If the heart can't adequately refill, it can't adequately pump blood. And if it can't adequately pump blood, we wind up right back here in the middle of our picture talking obstructive shock because the heart has lost the ability to refill and pump oxygenated blood around. So tension pneumothorax, that works by increasing that interthoracic pressure. And that interthoracic pressure pinches off those vena cava. Those vena cava means that the right side of the heart's not getting any blood to fill it up. And the right side of the heart not getting any blood to fill it up means the left side of the heart's not going to get any blood back from the lungs. If the left side of the heart's not getting any blood back from the lungs, it's not going to pump any blood out. Oxygen and sugar aren't being delivered. And if oxygen and sugar aren't being delivered, we wind up in anaerobic metabolism, creating all sorts of byproduct, creating all sorts of acid. The acid eventually rushes into those cells. The cells eventually explode. Once enough cells have died, tissues die. Once enough organs die, organ system dies. Once enough organ system dies, the whole metabolic machine fails, and the metabolic organism that we are dies as well. That is shock in a nutshell. It doesn't really matter which one of these things on our screen is causing the shock here. Figuring out cardiogenic, obstructive, distributive, hypovolemic is where we earn our keep. You know, tension pneumothorax is pretty easy to figure out. You know what we'll have? Distended jugular veins and absolutely no lung sounds, because the pressure inside the chest is so great that blood is backing up into the venous system and gas can't get into the chest. We can't create that pressure difference. But that's a lecture for another day. Right now, we're purely talking shock. Cardiogenic shock means my patient's heart cannot pump effectively enough. Hypovolemic shock means my patient doesn't have enough circulating volume to support perfusion. Distributive shock means the pipes have failed. The pipes now no longer can maintain their tone, and if they can't maintain their tone, we can't get enough pressure in the system. We can't get enough pressure in the system. Blood cannot get delivered. Hypoperfusion. Obstructive shock, we're still having a delivery problem. blood is being obstructed from getting back to the heart. So it's not really the same kind of problem as cardiogenic shock, but on the root of it, the heart is not effectively pumping blood because the heart is not able to effectively pump blood. So something is blocking that blood flow, and if that blood flow is being blocked, we have obstructive shock. How's everybody doing?
What?
Good.
So was that awful? Does anybody feel like that just completely missed?
No, it makes sense. Your body feeds off of oxygen and sugar. You gotta have to always make sure the air, the lines are clear. There's enough pressure, so, constricted to make sure that the blood's flowing adequately throughout the body. Anything when you get really cold, it's gonna fight to preserve those areas, make the muscles work harder. That's why we always throw a blanket on somebody that's going through hypothermia to help regulate their temperature. Seems pretty decent.
I definitely think looking at it like this and the way you explain it makes it easier to understand rather than just reading it out of the book.
That chapter in the book is
It's brutal.
it's well written, and it makes sense if you know what it is that it's telling you. But if you don't, I can see where you would just want to slam your head in that book and just want to wave the white flag at that point. But
Where was the electrocution? Which one?
electrocution, huh?
The nervic shock.
Probably abnormal heart rhythm, I bet.
Heart rhythm? Oh, so it's part of cardio? All right.
Yeah, I would imagine. Now I'm gonna have to get a textbook out because I don't even know what it is. I don't even know which page, like what that even had to do with. But I'll look. So how about the rest of you guys out there?
I don't think it was in the textbooks. I think it was on one of the things that I was reading about shock.
Oh, well, if you find it, let me see it, and I'll see what I can do to explain it. So anybody else out there with questions or just insurmountable levels of confusion? All right. Don't worry, this won't be the last time you see this. It won't be the last time we talk about this, because it is definitely one of those things that I circle back to all the time.
And again, a lot of that comes from, just pre-assessment when we're showing up on a scene and seeing a patient. We can get a lot of that information through them in the first, primary assessment.
Well, absolutely, because the next thing, we're going to take another quick break because we need a minute to decompress and digest and see if there's actually anybody comes up with anything that they want to ask me. But the next thing we're going to talk about is recognition and the body's response, because that's where a lot of how we're going to put these pieces together, because there's no actual like do this test and diagnose shock. That's
Right.
not the way it works. It is see these things glaring back at you and go, holy crap, this patient is sick.
Yeah. Most of it should be, self-explanatory, I would assume. You should be quick to identify, like, off the first assessment when you see the patient.
Boy, I sure hope so, because then that means I did this part right.
Okay.
So let's take 10 minutes, and when we come back, I'll open it up for questions again. And if there's no questions, we will put our heads down and finish this lecture off.
The metabolic shock, that we're gonna touch on that later on, right?
Yeah, we'll talk about that when we talk respiratory conditions.
Okay.
I think that's tomorrow. And when we start talking about inability to bring in enough oxygen or offload enough oxygen, it's way, way better when we're actually talking about respiratory conditions in general than to try and lump that into this, because that's where the waters get a little muddy, and shock can be tough enough without making it harder than it really needs to be.
Okay, thanks.
No problem. Anything else? All right, off we go. So if the problem is or can be traced back to pipes, pump, and fluid, what we need to do to make sure that we have adequate blood pressure and adequate oxygen delivery and carbon dioxide removal and getting rid of all those waste products is an adequate pump, an appropriately sized container, and enough fluid to fill the system. It seems pretty simple, and for the most part it is. What is responsible for controlling all of these things is going to be our sympathetic nervous system. Our sympathetic nervous system is what keeps the pump pumping the way that we need it to, the pipes the size that we need them to be, and those two things working hand in hand with each other is what makes blood go round and round. As long as there is still enough blood in the system, things will go on happy as a clam. Homeostasis will continue and things go well. When one of those things isn't going well, whether it's the pump, whether it's the pipes, or whether it's the fluid, the body releases pretty much the same chemicals through sympathetic nervous system stimulation, and that nervous system stimulation makes one of the systems work harder. So we don't have enough blood to fill the system. Okay, pump's got to pump faster. Heart rate goes up. Oh, we don't have enough tone to make the tank the correct side. Epinephrine goes out. Container size gets smaller. Blood fills the system. Pressure goes back up. And round and round and round this thing goes. When your body's just functioning normally, this stuff all happens all by itself and it goes just the way that it's supposed to. When one of these things isn't going well, whether it's a pump, whether it's a pipe, or whether it's a fluid problem, then we talk about the body starting to compensate. Compensation is just that. It is that direct nerve stimulation from the release of epinephrine. Epinephrine is going to increase the rate at which the heart beats. It is going to increase the strength at which the heart actually contracts. So now not only is it working faster, it's actually beating harder. The stroke volume goes up. The heart muscle contracts that much stronger to force out more blood from that left and right ventricle. The vascular system from that epinephrine is going to constrict, and we're going to make the tank smaller. And in making the tank smaller, even if there's less blood, making the tank smaller will maintain the pressure, because now we have a smaller tank to fill with a smaller amount of blood to fill it. Epinephrine is the chemical that causes all that. Norepinephrine comes from the adrenal gland and supports all of this. Both of those two things, those are both hormones that cause these known effects. And once those hormones get out, they get into the bloodstream and they act on these receptors. Alpha receptors in the peripheral vasculature. So alpha is what's going to cause our vasoconstriction. When epinephrine gets down to those alpha receptors and stimulates the vasculature to contract. When those beta receptors get stimulated, that's what's going to make our heart rate go up. That's what's going to make our cardiac contraction go harder. And it's going to, just for the time being, allow our patient to compensate. That is what is going to happen physiologically whenever your patient is involved in something that causes them to be in shock. But it is self-limiting. The body doesn't have an unlimited amount of epi and norepi to stimulate these receptors and just keep on keeping on until the end of time. That's why shock has stages. So let's take a look here. We have our early stages of shock, our early signs, the compensatory stage. Let's look at what we will actually physically see in our patient, because most of these things are just done with the eyes. Look at them. Restlessness, anxiety, irritability, apprehension. What's that sound like? What part of our primary assessment will we notice that?
Blood pressure.
We can start with what it isn't. Is it airway, breathing, or circulation? That we would notice them being a little restless, a little anxious, a little irritable, a little apprehensive, scared.
Right at the beginning when we introduce ourselves.
When we introduce ourselves, our general impression and our level of consciousness. So we'll see something in their level of consciousness that sticks out to us when they're in the compensatory stage. Think about times where your fight or flight instinct has been activated. You know, crossing the street and somebody comes booking around the corner and almost runs you over and you have to run to get away from the car. And you have that bit of anxiousness and your heart rate goes up. Your blood pressure is probably a little high at the point, right? You have that rush of adrenaline. So our early changes in our mental status is our patient is a little restless, a little anxious, maybe kind of cranky, a little scared. We'll see an increase in their heart rate a little bit. So their body is responding to that epinephrine. Heart rate might go up. Heart rate will go up. We may see a slight decrease in their blood pressure, or their blood pressure may be absolutely normal. You may take somebody's blood pressure with your blood pressure cuff and stethoscope when they are first involved in anaphylaxis, being run over by a bus, you name it. An epi may actually cause enough vasoconstriction to maintain their blood pressure in the early stages. But if we have all that vasoconstriction, what blood vessels might actually close nearly completely?
Peripheral blood vessels.
Peripheral blood vessels. Give that man a cigar. The peripheral vasculature. So my pale, cool, clammy skin that I'm going to be looking for. You know, your patient who's got cold hands on a warm day after being smushed by an MBTA bus, or your patient who just looks pale out at the periphery, the skin. The body in this scenario doesn't care one bit about whether it perfuses the skin or not, because perfusion is the problem. The body senses and knows that perfusion is the problem. So if perfusion is the problem, I'm going to make sure I perfuse the things that are important. The skin doesn't matter. So they look pale, cool, diaphoretic for no reason. We'll have an increase in their respiratory rate. We'll have an increase in the core body temperature. So the periphery gets cold, but the more midline things will warm up a little. Why do you think that might be?
It's trying to protect the organs and that are more vital, more important.
Spot on. The body has pulled all that blood away from the distal portions and brought it more midline, brought it more proximal. So the core of your patient's body will have plenty of blood that is 98.6 degrees. But the periphery, the distal portions are going to be a little bit cool. We haven't really hardly even touched this patient yet, right?
Nope, just plain observing.
Plain observing. And these are things that as soon as you see them, we can start thinking it's time to start preparing this patient for transport, because transport is the key treatment for shock. Yes, I'm going to oxygenate when I see all these things and I'm in my B of my ABCs. Sure, high flow O2, 15 liters per minute, non-rebreather mask. Sure, I want to transport them supine. Sure, I want to bring them to the closest appropriate facility with an ALS intercept en route and keep them warm. But transport is what's going to fix this patient. Transport is the treatment for shock, because until some form of definitive care is applied, we go from these early stages to now our late stages. When we get into the late stages of shock, our decompensated shock, all that epinephrine is beginning to wear off. And the body now is no longer winning the battle, because shock is a fight. Shock is a fist fight for the body. When we're in the early stages, the body's compensating, the body is still winning the fight. When we're in these late signs and symptoms and we're starting to see decompensated shock, the body's beginning to lose the battle. We see listlessness, apathy, confusion, slowed speech. So now your patient who was able to speak to you and answer your questions clear as a bell, now it takes them a minute. They have to think, because they don't really have enough oxygen getting to their brain, supplying enough perfusion for things to register quite as quickly. So we start to see decreases in my patient's level of consciousness. Now, instead of a slight increase in their heart rate, we see a patient who's got a heart rate in, the 120s, the 140s. We see a heart rate that begins to slow. So why would their heart rate start to slow down? It gets to a point, it gets really, really fast, and then it starts to slow down some.
It's I guess I'll take a shot. The heart has, exerted all of its energy and starting to wear and break down.
Absolutely. Not only is it slowing down and becoming irregular and weak and thready, it's starting to work its way down to zero, because shock without proper and appropriate treatment goes from early to late to irreversible and dead in no real uncertain time frame. It's just gonna follow this path. So we get a heart rate that is now raging crazy, crazy, crazy fast. And then the next time we check our patient's pulse, we realize, hey, their heart rate was 160, and now it's about 120. Did they get better?
No, they're getting worse because nothing has been done to treat the problem during the beginning issues.
The problem hasn't been reversed, so the patient's condition is continuing to deteriorate. Initially, in the early stages, we had blood pressure that was maintained. Our patient's blood pressure was remaining the same, maybe a small, small decrease. Now that we have what they call a precipitous drop in blood pressure, it means their blood pressure is now barely enough to perfuse even the important stuff. We may see a patient who's in some pretty decompensated shock who's got a systolic blood pressure of below 90. Really sick. Now, instead of just being pale and cool, they're actually cold and clammy and pale. So they actually are cold to the touch.
So Tom, the mechanic system that would help preserve the function for life will pretty much go into an overdrive, and then that overdrive eventually will just seize up, and basically that's how.
You eventually blow the motor.
Yep.
And
Okay.
you roll to a stop. Is really kind of the way all this goes. You can only push so hard before things begin to blow up. And once they start blowing up, they just start working their way back down to 0 RPM. Because even our respiratory rate, it's going to get fast. You'll have a really, really increased respiratory rate. And then our respiratory rate follows the same trajectory as our heart rate, and that starts working its way back down to 0. And just because you saw something start moving back down to what we would consider, quote, normal, unless you've done something to actually fix that problem, the patient's not getting better. Then we start to see our patient who is now at the core cold, and they're just following all this logical progression to getting worse. Their mental status fails a little bit more, so they are confused and incoherent. Their speech is starting to slur. Maybe they are completely unresponsive. We have depressed or absent reflexes. This is a patient you can put an OPA in and really have no reaction whatsoever. Your diastolic blood pressure, so that bottom number we're listening for. As we're listening, we get our systolic number, we continue to let the air out, and that blood pressure on the diastolic end goes all the way down to 0. You will hear no noticeable change. Then when we check our patient's pupillary response, their pupils are actually dilated and really slow to react. Why are we starting to see such change in my patient's mental status here?
Not enough oxygen to the brain.
Not enough oxygen to the brain, and the brain is going to stop doing its thing. And then the respiratory rate gets very, very slow and ragged and sort of irregular, very shallow, because there's not enough energy and not enough epi left in this patient to actually move their chest wall appropriately to get gas in. This is a patient you'll be ventilating with a BVM for sure. And then we get to a point where there has been enough dysfunction and enough failure that shock becomes irreversible. Even if we get the patient to where we're going alive, once shock has become irreversible, what winds up happening is there's been so much damage and so many organ systems have been damaged to the point of no return that a couple weeks later they die in the intensive care unit. It's called multi-organ dysfunction syndrome. Someone has been in shock, they've traveled through all these stages of shock, they've compensated for a while, then they've decompensated. After they've decompensated for long enough, there's been so much destruction that shock is truly irreversible.
So it's like too much mileage on the emergency system.
Yep, absolutely, too much. You can only ask for this kind of response from the body for so long.
And it'd probably most likely be like a short amount of time, correct? I mean, because
Yeah.
longer you go, you're exerting all your energy and resources.
Right, depending on how significant the insult to the body's systems are, will tell us how fast our patient's going to go through this. Even, people that are hit by a train and completely transected, cut right in half. All of this stuff is going to happen, but since they've been cut in half and the aorta's been severed, it happens in the blink of an eye. Versus somebody who is in anaphylaxis and these body systems really one at a time are beginning to fail and fall off. So what out of all of these seems the easiest to recognize and realize that our patient's in some trouble? Where do you think the best point of intervention would be?
Right as soon as you see your patient for the first time and lay eyes on them, start checking for your basic vital signs.
Absolutely. As soon as you lay eyes on a patient and you identify this kind of stuff, that's when to start thinking, all right, I need to transport this patient. That's why at the end of our primary assessment, we will have found all of these things, would we not?
Yes, if we're doing it correctly, step by step and reassuring over and over and over.
For sure. So if you do your primary assessment and do it appropriately and do it the same way every single time, these things just jump right off the patient and go, hi, I'm someone who's trying to die this morning. Could we do something here? And you intervene right then. You get the oxygen on them. You make that transport decision. You make that transport decision quick, fast, and in a hurry. And then every other single step that you take is to either treat shock or get that patient rolling. Make sense? Because when we start getting to here, all of these things become way more difficult to fix.
So when you find somebody with the late signs, you just boom, hit them with epi right off the cup.
So if it was an anaphylaxis, yeah. I mean, now we'll talk the difference between street medicine and classroom medicine. When I go to like these educational seminars and stuff like that, and we talk about EMS education and whatnot, and they say, well, there shouldn't be that big of a difference between how you would do things in the road and how you would do things in the classroom. And then I have to sit here and tell you that you have to go through all 19 steps of your medical assessment before you give the clearly attempting to die anaphylaxis patient epinephrine, or you've blown it. But as far as like in the street, I think I had this conversation with somebody the end of last week, was, we'd walk up, we'd see the patient who's, having respiratory distress and covered in hives and stridor and all the whole shooting match. And we'd see the cookie crumbs in front of them on the table and go, hey, are you allergic to peanuts? And they'd nod. And then I'd say, do you think there were peanuts in that cookie that you just finished eating? And they'd nod again. And then I would give them epinephrine.
Seems logical. 2 + 2 = 4.
Right. But as far as like what I expect of you here, we follow different rules in the classroom. And it's just because we need to be able to get from A to Z and every point in between. You will see that when you actually get out and start doing this for real, that things are a little different. All right, we just did all of this. So let's get to. So I mentioned earlier that the two outliers as far as age go are the ones that struggle with this the most. And there is some reasoning behind that. Specifically, elderly people, first of all, they don't have the stores. They don't have the muscle mass that people that are in like middle age have. So they don't have the body's own ability to protect itself. Then you add to that some of the medications that people get prescribed specifically for high blood pressure, for one, which is something that is rampant in the world. There's so many people, especially as you get older, that don't have their body doesn't have the ability to correct its own blood pressure problems. So they get prescribed a medicine and their blood pressure is great from then on out. Some of the medicines that people will take for control of their hypertension are what they call beta blockers. So if we think back to what we were just talking about, and that direct nerve stimulation and epinephrine acting on beta 1 to increase the heart's ability to beat faster and increase the heart's ability to beat stronger and increase the body's ability to control that vascular tone. And then Grandma Ethel here takes a medicine that takes that right off the table, because she takes a medicine every day for her hypertension that will prevent her body from being able to respond to that epinephrine and raise her blood pressure or contract her vascular system or increase the rate and strength at which her heart beats, because, well, Grandma Ethel doesn't want to have a stroke. But when something happens to Grandma Ethel and, maybe her heart starts to fail for one reason or another, or maybe she gets stung by a bee for the first time in 65 years, and she remembers that she used to be allergic, and we start to see signs and symptoms of anaphylaxis, she's not going to be able to mount that same compensatory response, because she takes that pill every day to control her high blood pressure. And that pill blocks the body's ability to respond to the one thing that's going to keep Grandma Ethel alive, because that's the way the body compensates for shock. So advanced age is a hindrance when we talk compensation with shock. Medicines can be a big stumbling block for us when we talk about an elderly patient's ability to compensate for shock. So a lot of the times, if we have an elderly patient who's been involved in something that we think may cause them to be in shock, which stage of the game do you think we find them in?
Probably the late stage.
They're decompensated already.
Yep. Their
Absolutely.
bodies, they got too much mileage in their body to help with the issues that a normal person could be able to address because of the
Yeah,
medication they're on.
and the things that they're putting into their body are actually directly counteracting what it is that the body is supposed to do. Those beta blockers are actually physically blocking the abilities to compensate. When we talk about kids have all these fresh new organs and everything's at its optimum and it's functioning as good can be. So kids have the ability to clamp down their vasculature to almost nothing. They can increase their respiratory rate super high. They can increase their heart rate super, super high, and they can compensate next to forever. And then once they get to that point that's next to forever, you know what kids do? They stop altogether. Kids will compensate, look great, no problems. We're going to transport, we'll get out of here. Everything's going swell.
Then they seize up.
It's like somebody threw a light switch, and the next thing you know, you are in decompensated, very, very, very much behind the 8 ball, and have a wicked sick child in the back of your ambulance.
Tommy, I've got a question that may be kind of off topic, but this picture is making me think about it.
Sure.
In relation to little people or midgets, are we treating them more like a child, or are they like an adult, like as far as, you know, their organs or everything are concerned?
So it's still dependent on age, right? Because they may be smaller in structure, but everything still should be functioning up to age level at that point. That's a good question.
Well, it's like as if you had I buy a brand new motorcycle. They tell you to ride it, but don't, stop banging through the gears because it hasn't had all the proper progression of getting into its maximum area of where you're allowed to run 1,000 miles an hour.
Sure. And kids will run that 1,000 miles an hour right out of the gate. Sure, no
Right.
problem. Until there's a problem. And then when there's a problem, there is like a number one big freaking problem because their bodies just don't have the reserves to pull from. You know, we have fat stores, we have sugar stores, we have all sorts of things inside of our person that our body will call upon to continue to compensate and continue to hold things at as much of a status quo as it can.
Right.
Kids don't have it. And
yeah, they haven't developed enough of that yet throughout the years.
Right. And when they're placed under this kind of physical stress, it's only going to last for so long. So that's why shock is something that we treat aggressively and we manage aggressively, and we always, always, always aggressively and rapidly move towards transport, because I need to get this patient to where absolute definitive care is going to stop this problem from progressing and reverse some of the things that have been happening. And this is how we do it. So none of this should look particularly foreign at this very moment in time. This looks like my primary assessment, no?
Yep.
Stop any external bleeding, secure and maintain an airway, ensure adequate ventilation. So if my respiratory rate is too fast and I'm seeing poor chest rise and fall, well, I'm going to ventilate. If my patient is still in the early stages and we've gotten here soon enough, I'm going to provide for them high flow oxygen with a non-rebreather mask at 15 liters per minute because their body is still bringing in enough gas. I'm just giving them more of it because oxygen delivery and glucose delivery is the problem. So if I start working on the oxygen piece of this, the sugar piece of it will fix itself. I'm giving them a much higher concentration of oxygen. Gas moves from high concentration to low concentration when it gets to the alveoli, and I am starting to help this patient's body start to win the fight. Oxygen is not one of those things where some is good, more is better. So if you are ventilating a patient, stick with that one breath every 5 or 6 seconds. Hyperventilation is not going to make them better. So breathing faster for your shock patient that you're ventilating, not helpful.
No, because they're not getting the full amount of oxygen they need to fill up their lungs, correct?
And we're eventually just going to make them vomit, and we're going to screw up all their blood gases, and it's really just, it turns into one nightmare feeds the next, and your patient just doesn't get any better. Splint any fractures to try and reduce any internal hemorrhage? Sure, but that's sort of low down on the list of priorities, not to mention the fact we have a long backboard that we could put a patient on and apply as a full body splint. We don't need to sit there bandaging fingers and broken wrists because my patient's in shock and trying to die right now. So we need to get that sorted out. We don't remove, go ahead.
Oh, so we're addressing the main issue right there and then, and not worrying about the little stuff, pretty much.
Yep, the little stuff we can always do in transport. Any of the little button-up type things and cleaning somebody up and making them look all nice when we get to the emergency room is great. But if you're doing that on scene, you're wasting their last few minutes because it doesn't do us any good to show up with a well-packaged dead body. If the patient's got anything impaled in them, we're going to stabilize those and leave them in place. We don't pull anything out because if that impaled object is sort of applying some pressure to something that would otherwise be leaking, and we remove it from our patient, guess what it's doing now?
It's going to be a main artery, like a main amount of blood flowing out that's going to kill them faster.
It's leaking and we're just going to kill them faster. You're absolutely right. We want to keep them warm. We want to provide rapid transport in any intervention that is not involved in getting this patient packaged, getting this patient transported, or dealing with the fact that they are in shock can be done in the back of my ambulance on the way to the emergency room. We always want to consider the need for ALS. If we need it, that's great. Ask for it early and you're more likely to get it. If your closest ALS is going to be the CHA in Everett, well, they keep doctors and nurses there for a reason. So transport that patient to the CHA in Everett. Never, ever wait for another EMS provider to show up because we can just bring them to the emergency room and support their airway, breathing, and circulation. We can keep them warm. We can monitor for any changes, and we can really do the real nuts and bolts of caring for our shock patient just by getting them moving to where the definitive portion of the patient care lives and making sure that we do the things that are supporting this patient as a human and helping their metabolism, helping their perfusion continue to win the struggle. So that was shock. Anybody wildly confused?
Yeah.
That's okay. We'll talk when you get here. If you have questions that would be helpful, bring them with you because we'll go over this the whole rest of the day if we have to. What was the part that confused you the most, you think?
I'm not even too sure. I get like why shock happens. It's just the different types of shock, I think, is what's confusing.
Oh, that's no big deal. We'll get that nailed down. You're gonna see how all of this stuff kind of loops back to shock when we do the actual lecture on that body system and on that emergency. So if that's your sticking point, we're in good shape.
Huh? All right.
But no, we can work that out probably today anyway, I bet. And then when we actually do the lecture on that particular piece of the human, we'll get that squared away.
Oh, awesome. Thank you.
Yeah, no problem. Anybody else?
Yeah, Tommy, quick question. So all shock is just pretty much caused by a drop in blood flow?
In some way, shape, or form, sure. It's oxygen not getting delivered, which is causing the hypoperfusion. And then the hypoperfusion starts the rest of that cascade, the anaerobic metabolism, the increase in byproduct, the increase in waste product, a lot more acid. Acid gets into the cell die, tissue die, organ system die, organism dead. Is that what you were asking, Jonathan?
Thank you.
Yeah, no problem. All right, who else? All right, well, if that's all you guys got for questions, we are for sure not adding anything to today's lecture because shock is big and it's a lot of stuff to think about. It's a lot of stuff to discuss. And as long as the real only sticking point is the different types, that'll clean itself up. That's not a huge deal, Pat. So we'll get that sorted out.
Cool. Thank you again.
Yeah, no problem. So other than that, I'll see you fellas at 1 o'clock here in Malden. We're going to be in the upstairs classroom again because we're the only ones here today. So I will see you all shortly.
Sounds good. Thanks, Tom.
Thanks,
You're welcome.
Tom.
Thanks,
you.
Tommy.
Take it easy, guys.
Thank you, Tony.